Good evening. All right, why don't we get started now this evening? Look, I have a very simple task here tonight. Welcome people, make sure that we're prepped and ready for what should be a great discussion. I'm Stanley Brown. I'm the interim dean of the Dalai Lama School of Public Health, and I'm thrilled tonight that we've got essentially a sold-out audience for what is a really, really important debate in health policy, but more broadly about the type of society that we want here in Toronto and that we want here in Toronto, in Ontario. Look, before we start, I want to acknowledge the land on which we sit. It's the traditional land of the Huron-Wendat, the Seneca, and most recently, the Mississaugas, the Credit River. And today, this place is still a meeting place for Indigenous peoples from across our nation. And I want to make sure that we're making it clear we're grateful to have the opportunity to work on this land. A few housekeeping items. For those of you who are younger than me and are tweeting, the hashtags tonight are DLSPH leadership and hashtag opioid crisis. Also, and this isn't relevant to you, this lecture tonight, this series is being live webcasted, so you shouldn't be watching the webcast and here, but you can actually point out to folks if you're emailing them now. And then finally, I also want to say I'm grateful to the Faculty of Law for letting us use this beautiful space. It's nice for us to be able to have a discussion and a debate about decriminalization in a law school. It's particularly nice for us to have this beautiful space to use. And as a dean, one of my jobs is to wave my hands around and ask for money, it's nice for me to remind you about how nice schools of public health could be. So if you ever get an appeal from us, keep in mind this room. So look, this is our fifth leadership event, and all of them have touched on controversial topics, but our keynote speakers promised me tonight to make this the most controversial we've had yet, which I think is great and exactly what we need to do, because it's all about stimulating debate on the critical issues facing the health of Canadians, and I think more broadly the health of people across our planet. So with this in mind tonight, we're delighted to present this evening's keynote presentation and panel discussions, and it's the opportunities and challenges related to the decriminalization of drugs, including opioids here in Canada. And this is a critical time to have this discussion. There's not a day that goes by that someone doesn't say, do you know opioids killed more people this year than and insert whatever health crisis you thought was dominant? This one is keeping pace and beating. First time someone told me that caught my attention was that it's more than AIDS. Now it's starting to creep up in terms of other major public health risks. And so this is truly a public health crisis that we can't treat as anything but a public health crisis. One of our own researchers pointed out there was over 700 deaths in 2015, and the early statistics show that it just rises every year. And so one that we're not going to get away from. I will say as well, this is one that I think a lot of people in the room has touched me personally. When I was in government, I came in from the Christmas holidays one year to find that my clerk had disappeared and no one could find him. And unfortunately, he'd gone home on Christmas Eve and cut open a fentanyl patch. He was just a wonderful guy. And it caught all of us by terrible surprise, but I think it was an early warning of what we're dealing with. And so for those of you who have been touched personally by this, and for those of you who this may be a sensitive subject, thank you for being here tonight too. I know that's a challenge at times. Okay, so in response, we have done some things in this province, in this city. We've opened up supervised injection sites and two more temporary ones recently in Kensington Market and Regents Park. And I think you're going to hear tonight from our speakers that the science behind supervised injection sites is clear. They're effective, evidence-based public health intervention that works. But it's clear, and I'll take a position right off the start, that they're not enough. And so there's more that must be done. So Portugal is one example, one case study of a country that has decriminalized drug use and as a result dramatically improved public health. But there's always a challenge when looking abroad and saying what works here. Is this a model that works for the Canadian health system? Is this a model that works here in Ontario within our healthcare system? And it's a question tonight that Donald MacPherson, our guest speaker, is going to be addressing. We've got an important panel of folks here with us to respond to this and talk about it with us as well. We have people who are experts, people with lived experience, people who've been touched personally by this and who can bring a scientific or an evidence-based approach to it. We have a frontline harm reduction worker, and so I won't go through all of this. Carol will introduce all of our speakers, but it's the type of discussion that we need. And tonight, I'm hopeful that you'll take a few things away from the discussion. The first is an understanding of the context and what drug regulation and harm reduction, decriminalization means in Canada. There are other countries and models globally, but this is our chance, hopefully, to make a made-in-Canada solution that isn't novel just to be novel, but builds on the best of what has worked across the world. Second, this is an opportunity for us to try to create the broad engagement that goes beyond just experts, health policymakers, and healthcare workers, but to include other scientists, police services, people who use drugs, and beyond to create a better regulatory environment in Ontario and in Canada. And finally, and I guess we're kind of staking claim here, it's in our DNA as a school of public health to want to make sure that healthcare is accessible to all people. But we have to think about health services and ways of approaching health that are accessible to all people as well, so that we can truly realize that idea of health for all that's supposed to be embedded in our promise around universal healthcare. And so with that, I'm going to introduce our guest speaker tonight. I will confess up front to a sin of omission. There is a lot of paper that I could consume talking about his achievements. He and I both agreed that it's better for me to leave things out rather than keep you here. But with that, let me at least touch on a few high points. Donald MacPherson is currently the Executive Director of the Canadian Drug Policy Coalition. This is a national coalition of organizations and individuals working to improve Canada's drug policies. He's based at the Centre for Applied Research in Mental Health and Addictions at Simon Fraser University and involved in drug policy work at the local, national, and international levels. And now there is a list of recognitions and achievements. I'll just note one of them, which is the Queen's Diamond Jubilee Medal in 2013. But it is all around the work that he has led through the 4-pillar strategy in Vancouver and more broadly about how cities and jurisdictions can actually create workable drug policies that actually improve public health. After Donald, Carol Strike will be coming up. Carol is the division head for our Division of Social and Behavioral Health Sciences, someone who has authored a hugely read and hugely downloaded text on harm reduction and an expert in her own right on this topic. But with that, Donald, can I welcome you to the stage?
Good afternoon. What a beautiful day. So sunny, so warm. What are we doing in here? Thank you so much for the introduction, and it's a real pleasure to be here to talk about something. There are so many discussions going on across Canada around this issue. It is absolutely mind-blowing. There are groups of people at all levels of society meeting as we speak, pulling their hair out, trying to figure out how to stem the tide that has swept over the country in the last few years of overdose deaths. I'll just say this is not a TED Talk. I didn't memorize it. You know, you have to memorize TED Talks? Really? So who knows where it will go. I have to first of all figure out how to work this mouse. It's not connected to a PowerPoint thing. I thought I was going to flip through the slides of our pictures here for a minute. There we go. Great. And is it arrows? Or, yeah, okay. So, decriminalize opioids and other drugs in Canada, that's the title that was chosen for this. I think I'm going to wander away from that a little bit. In the introduction, we talked about having an opioid crisis in Canada. I'm not so sure we have an opioid crisis, but we do have an overdose crisis. And there obviously is a relationship between the amount of opioids and the overdose crisis. But we have two real issues before us, and much of my context is informed by the work in British Columbia, but I've traveled a fair bit in the country and internationally in the last several years. And in BC, there's this tension between responding to these massive amounts of overdose deaths in the country, with people thinking we have an addiction problem and that we can treat our way out of this problem. Or we don't have enough harm reduction to supervise people who are injecting or using opioids. And we need a better system. And the other thing we have is a crisis that we have to respond to immediately. So we have a challenge of building a system over a number of years and working amongst the different jurisdictions and health authorities and sectors to build a comprehensive system of treatment and care and response for people who use drugs, that develop problems with drugs. And while we're doing that, right now we have this overdose disaster that is taking place, and we need to respond. And there's this tension between people like me and many in the room probably that are demanding action now, and people within systems that are working as hard as they possibly can to build better systems of response inside the systems. And I say that because I feel it when people are just killing themselves to try and get a few extra treatment resources in place or another supervised injection site up and running. We don't mean to demean that work, but frankly, we need a different response at the same time that complements that incredible work that's going on. This is just, that was 2016 in Canada. You'll notice how the West, the overdose deaths are very much in the West and in Ontario to a large extent. Why is that? We don't know. I know in the 90s when I first got involved, we looked at the heroin was coming from Myanmar, Burma, Myanmar at that time in the late 80s, early 90s. And it was very much, British Columbia experienced a terrible overdose epidemic in the 90s, from 93 to 99, 2000, and it wasn't as bad in other provinces. And we have a similar situation going on. There is one theory that this has to do with the drug cartels and the triads, the fentanyl coming in, illegal fentanyl coming in from China and coming to Calgary and to Vancouver and being distributed there with the connectivity with Mexican cartels who are distributing it into the US. So it's a highly sophisticated market shift, just as we saw in the 90s, that the heroin became stronger and more plentiful on the West Coast. And something shifted in the international drug markets. Some decisions that were made in the international drug markets that changed things. And these are things that we have no control over. The same thing is happening here. Something has happened in the market, the illegal market. In Canada, 3,300 deaths in 3 provinces alone this year. So it continues. Fentanyl is showing up. Carfentanil, which is a much more powerful fentanyl, is showing up. And this epidemic of overdose deaths shows no sign of really decreasing. Numbers are a little bit down in British Columbia, but not that much. This is a self-explanatory slide. Something happened in 2012, 2013, 2014, and the spike are fentanyl-related deaths. If you look at the overdose phenomenon, overdoses in British Columbia are actually going down if fentanyl was not in the mix. And fentanyl was not in the mix in 2007, 8, 9, 10. Fentanyl came into use in the early, in the teens. And so this is a very different problem than trying to address an ongoing level of overdoses of 150 or 200 when you're trying to really engage people and get them into more treatment programs, etc. This is what is causing the disaster. We had an event in British Columbia, in Vancouver, last week, and it was called "The Well Has Been Poisoned." So people in British Columbia are calling this a poisoning crisis. It's not necessarily one of addiction. People are being poisoned by substances that in 2007 or 2008 would have been they would have been buying a substance that they would have been receiving a substance that they thought they were purchasing. Now you don't know what you're getting when you buy from the illegal market. And this, unfortunately, is happening at a time when the predominant attitude towards people who use drugs is fix at your own risk. And this is an image from the 90s in Vancouver in a back alley. This is just the way that we've approached this subject. The criminalization of people who use drugs, the criminalization of drugs has led to an extreme amount of marginalization and has maximized the risks of substance use for people using drugs. These are the guys that we as a society have chosen to distribute drugs. When we prohibit something, we're really making a decision to not distribute it. We're also making a decision to have other people distribute it, especially when there's a high demand. And there is a very real demand for opioids in Canada. This is the United Nations gang, another gang, and I couldn't get a picture of the triads because they're much more secretive about where they meet. But this is truly what we've done. We've created a system that has given a highly toxic market to a bunch of organized criminals that are very well connected in this hemisphere and across hemispheres. And this is the result. This is from 1998, when we had 400 overdoses in British Columbia. That was world class in the sense that people looked at Vancouver and British Columbia and said, what the hell is going on there? We thought that could never happen again. How naive we were. And this is what we fought for in the 90s, you know, a safe place for people to come and use, as opposed to this. And we've made some progress, obviously. Because drug policy is inherently political, we got stuck. The Harper decade was a decade of no scaling up. We had a public health emergency declared in 1997. We had interventions that we wanted to implement. They finally got implemented in 2003. They should have been scaled up across the country. They should have been scaled up wherever needed. The Harper government put a big chill on the implementation of supervised consumption services, and we got stuck. And since the fentanyl crisis, you've seen a massive scaling up. It's so bad now. 1,500 people in British Columbia, 4,000 people in Canada. It's so bad that people are waking up. And so this is Mayor Nenshi in Calgary. You know, we all love Mayor Nenshi. He's such a cool guy. And that was the headline. No fan of supervised injection sites. Calgary's Mayor Naheed Nenshi describes supervised consumption services. I find that they almost feel like an admission that we're not able to solve the problem. Yes, we're not able to solve the problem. He's so close, he's so close. But that said, my personal feelings aside, the evidence is absolutely clear. Absolutely clear. They save people's lives, and our job today is to save people's lives. Poof, 7 federally approved supervised consumption services in Alberta. There's 8 in British Columbia. I don't know how many in Ontario, but we have over 40 or 50 overdose prevention services in the province. It's becoming a sort of, it's commonplace in every housing project that there's an overdose prevention service in a room, because that's one thing we can do. We can't control the drug market. We can't necessarily get people into treatment if there was treatment or if there is treatment. What we can do is we can help supervise people like lifeguards, so people are being enlisted to learn how to use naloxone, and we're really, really like lifeguards in this disastrous situation. It's the one thing we have control over. The prohibition created the problem. People aren't dying of fentanyl overdoses. Well, they are, but they're dying because drug policy is killing them. Prohibition has created fentanyl. Prohibition creates small packages of highly concentrated substances, just like it did in alcohol prohibition. Wine and beer were not smuggled across the borders. Spirits were. Pure alcohol was. This is something we've learned before, and it's the Iron Law of Prohibition. The tougher the enforcement, the harder the enforcement, the harder the drug. This is again, it's a policy decision that we make and keep reinforcing and keep maintaining. There really is no way out of it except to change the policy. The United Nations, a drug-free world. This is from 1998. This was the UN General Assembly Special Session on Drugs in 1998. This was an event that set a 10-year goal, a drug-free world, except for alcohol, tobacco, and pharmaceuticals. Those weren't the drugs they were talking about. They were talking about the bad drugs used by other societies, opium, coca, peyote, these sorts of things. And the United Nations Commission on Narcotic Drugs actually published something that by now problems have been clearly defined and some of them have been solved, or the instruments of their solutions have been created. Non-medical consumption of opium, coca leaf, cannabis, and of the drugs manufactured from them is outlawed in principle and is bound to disappear after transitional periods of adaptation. This was really what they were thinking. They were thinking that since they'd made all these rules about who could do what and who could consume what, that eventually, if they got organized enough, they'd just disappear. Coca would disappear, opium would disappear, all of those things would disappear. That's how diluted they are. Here's a tweet from the Surrey RCMP yesterday. Multiple dosages of street-level drugs, including suspected fentanyl, seized during a search warrant near 135A Street this week. Investigation will have significant impact on illegal drug activity and overdoses in this area. So this is I guarantee you that it won't have any impact. We've seen the trophy bus, right? The police with these you can only see their heads because there's pounds and kilos of heroin in front of them, and taking it off the streets. We took $2 million worth of heroin off the streets of Canada. The Center for Excellence in HIV/AIDS studied one of those busts in Vancouver. They have a cohort of people who use drugs, and there was no one noticed it at the street level. No one noticed it. Well, the drugs were going somewhere else probably, but they weren't off of the streets of Vancouver. The same year as this UN UNGAS meeting, UN General Assembly meeting, there was a real beginning of a turning the tide on drug policy reform, when a whole bunch of people wrote to Kofi Annan, lots of judges and politicians from around the world that basically said, the war on drugs is causing more harm than drug abuse itself. And this was an important moment in terms of the movement to reform drug policy. The Consumers Union report came out in 1972. 1972, the Consumers Union. These are the people that tell you which TVs to buy and which radios work best. And they were concerned about the consumers of illegal drugs. And they wrote a very, very massive report on licit and illicit drugs. It's one of the best reports written at the same time that the Leigh Commission in Canada was writing a very good report on drugs. So we've really lost our way, because it is 2018, I think. And they basically were saying, if you're addicted to heroin, you should not have to go to the illegal market to buy it. You should be able to get it because you have a health issue. This is one of the organizations that is one of the many organizations, civil society organizations across the country who are, you know, moms, a bunch of angry moms are about to descend on provincial and federal national capitals because there's not enough action on this issue. And so we're meeting in Victoria on the legislature steps, and it's an amazing group of moms from across the country who are basically advocating because they've lost children, which has been just devastating so many families. I'm going to talk a little bit about the Portuguese innovation because you hear it every day. You know, we should do what Portugal does. Portugal legalized all drugs. No, they didn't. It's very complicated to have these policy discussions in the media because the journalists get it wrong. Portuguese decriminalized drugs very quietly in 2001, and they did it without big fanfare, but they did it as a response to a disaster in their own country. Overdoses were high, HIV was high among injection drug users, and they actually pulled together a commission of people to work on this, and they came up with a plan. And they innovated. Decriminalization law reflected a shift in philosophy. They really felt that they were going down the wrong track. They believe strongly that people will continue to use drugs for a variety of reasons, which is true. A drug-free world is impossible, which is true. Criminalization and punishment is not a proportionate response to substance use. They implemented a comprehensive plan with the resources that they had, and it was a national plan. And they began to move forward. They staffed up these, what they called dissuasion panels, which were, instead of, there's no way if you were a drug user and you were using in a park or using on the street that you could end up going into the criminal justice system. Their whole effort was to try and walk the talk of this is a health, problematic substance use is a health issue. And to try and to do that, they tried to really put a lot of effort into referrals to other kinds of services and engagement with people who use drugs. So the police who were against it in the beginning actually are working with it quite well now, and came around. Their jobs changed. They became to refer people to people who might actually help them. The dissuasion committees are something that we have trouble grappling with. You're going to dissuade people from doing something by, it's verging on the issues of coercive treatment. But if you look at the numbers, it really 81% of the people who go visit a dissuasion people, there's much more of an essence of engaging and getting in contact with people and trying to refer them to helping services. Why is everyone talking about Portugal? Because they implemented a comprehensive approach that maximized sort of engagement, harm reduction, better coordination. They scaled up treatment over time. And none of this is fancy stuff because they're a small country. They're one of the poorest countries in the European Union. So it's not as if they spent billions and billions and billions of dollars. They just got better at what they were doing, and they started caring for people differently. And this is the architect of the Portuguese model, João Goulão. And you know, he says it's impossible, it's difficult to, you know, connect what we decriminalize. It wasn't the decriminalization, it was the spirit of removing criminalization from people who use drugs. It was the spirit of walking the talk of let's really make a societal effort to change the way we approach people who use drugs. The results were good. Things worked. You you can't say it was because of decriminalization. I mean, many people say that you know, the best thing about Portugal, they decriminalized drugs and nothing bad happened, which is sort of what has happened where drugs have been decriminalized in other places. The states that decriminalized cannabis in the 70s, nothing bad happened. So decriminalization to me is a no-brainer. It allowed the police to also focus more on the major trafficking, and increased amounts of drugs were seized. So it was a way of giving the police more appropriate work than chasing people around their cities and towns. Just some of the stats: drug-induced deaths went way down. New cases of HIV/AIDS. HIV was a huge concern in the 90s in Portugal. You know, drug use didn't skyrocket, drug tourism didn't skyrocket, and generally it didn't solve their problem. It improved things for everybody, and I think you'll get a broad consensus in Portuguese society, and if you talk to the Portuguese people who implemented this, things got better. They still have problems, of course. And drug use has not increased, and they're below average in the European Union. And try and find Portugal on that list. We helped you. They have a very, very low rate of overdoses. They don't have fentanyl, though. So that's a difference. And I guess what we have come to as an organization, we're a coalition of organizations across the country, is that we do need to decriminalize drugs. There is no upside to criminalization. You make the police jobs work more difficult. That's what I'm trying to say. They'd fire me if this was a TED Talk. They say, you didn't memorize that line. You improve people's lives by getting them more access to health services. There's just no upside to criminalization. It's all downsides. It's harsh. It's silly. Uruguay never criminalized people. They never bothered doing that. I mean, it was not like we had to. It was a choice. We thought, North American society thought punishment was a good thing, and that would work to deter people from using drugs. The Europeans were much more about, I don't know, maybe we can reduce the number of people who use drugs by doing a whole bunch of different things, but criminalizing them, there's just no upside to it. So our organization, of course, supports decriminalization, and I think you'll hear some examples of decriminalization in Canada. There are some places, the Vancouver police have de facto decriminalized cannabis. They don't really arrest many people for cannabis possession anymore. It's not the same for harder drugs, but you can do things in a de facto way, just by changing your administrative procedures and your enforcement priorities. And all police should do that now. In the midst of an overdose emergency, which the federal government won't say, the police should back off. Their number one priority should be, which it is for everything else, is the protection of human life. And to do that, they need to stop criminalizing people who use drugs. They need to help people get to safe places to use or access safer drugs. So what we're advocating is a public health approach which argues for regulation. So take the drugs away from the United Nations gang and the Bacon Brothers gang and the triads. Take the drugs from them and say, okay, you guys have had 100 years to do this, and you've really messed it up. You've really made a botch of it. It's a horrible situation. People are dying. We think we can do better. So it's our turn, and it won't be perfect, but in this field, you're looking for the least worst. The least worst way of regulating drugs is something we could probably do, because the Hells Angels and the Chinese Triads and the United Nations gang are the worst. They just don't care. There's not a regulator among them. There's a great resource for looking at it's called Count the Costs, and it's put out by the Transform Drug Policy Foundation, and it looks at the costs of the war on drugs, the costs of maintaining a prohibition regime around the world in these areas. Certainly undermines development and security and fuels conflict. Think of Mexico, think of Colombia, think of Central America. Just horrible, horrible things going on in those jurisdictions. It threatens public health, spreads disease and death. That's HIV, overdose, hepatitis C. Wastes billions on law enforcement. Global drug use has gone up in the last 10 years, if you look at the numbers. So the billions we're spending on law enforcement, causing immense amount of harm. Creates criminal, enriches criminals. So whatever we're not selling, they are selling, and there's a huge global market to sell drugs 24/7 in every city in the world. You can buy drugs, illegal drugs. It promotes stigma and discrimination. It's sort of a punishment regime where people who use drugs are they're the ones that sort of are the hardest hammered. You never get to the guys in the towers downtown who are really moving the drugs in and out of the country. You never get to those guys, or rarely. Deforestation, pollution. Think of aerial spraying of the cocoa and coca leaf in Colombia, or the opium poppies in Mexico, Afghanistan, and other countries. And of course undermines human rights. What is done in the name of the drug war, in the name of prohibition, is absolutely the death penalty, for one, in 22 countries is still on the books. People's lives are taken for a kilo of heroin or cocaine. And whole families are incarcerated because of methamphetamine use in some countries in Southeast Asia. What is done in the name of trying to protect communities or trying to keep drugs out of countries is absolutely abominable, I guess is the word. And a public health approach also acknowledges there will be problems with a regulated market unless, and we're seeing this with cannabis right now. That's the irony. As the overdose crisis is happening and people are dying, we've taken the least harmful of the illegal drugs and we're regulating it. If you take our Minister of Public Safety's Ralph Goodale's speaking notes on cannabis and just replace cannabis for heroin, you would hear him arguing, we are going to regulate heroin because we need to protect our communities, we need to protect our children and youth. Heroin is now being sold by organized criminals, and we are going to sell it through a strictly regulated market. Or then take cocaine, and we could do that one. But it's cannabis that are in those speaking notes. And there's no reason not to do it. All the logic that applies to cannabis applies to other drugs. You'd do it differently. You might not have heroin dispensaries. You might have heroin in clinics, like it is in one program in Vancouver and in Switzerland and Germany, so people could actually access real heroin. The corporate profit side is something that public health worries a lot about at night and loses battles often. Certainly with alcohol, I'd say public health has lost a lot of battles. Not so much now with tobacco. The tussle with the cannabis industry and public health frameworks in the provinces is going to be a very interesting study coming up. A public health approach would allow us to begin to look at the benefits of substances. All of our rhetoric and all of our sort of policy discussion is reduce the harms, reduce the harms, reduce the harms, reduce the harms, when in fact there are benefits to opium, there are benefits to heroin, there are benefits to cocaine, stimulants. And besides, you know, if people are using these substances and not really causing harm to others, what's the big deal? Psychedelics are emerging as part of this sort of movement to emerge out of this global prohibition. They're being used in therapeutic context. There's more research going on. Prescription heroin and stimulants have been used in therapeutic context, certainly in Europe. Decriminalization is a step in that direction. Regulation of cannabis, drug checking is the least we can do, and that's a growing field, which I think Nazlee is going to touch on. So we have, you know, we have an opportunity to move in a direction of a public health framework, and try and move as much as possible these substances that were formerly in the hands of those guys at on the slide, the UN gang, etc., into a more controlled, thoughtful regime where people have access to them, either with strict regulation or with light regulation, and there may be some things you do want to continue to prohibit, but base the public health approach to drugs on the evidence that we have before us of their harm, and of the acknowledge the benefits of some of these substances, and not to treat all of these substances the same. Maybe I'm too logical, but that seems like something that could be achievable. And the irony is we're doing it with cannabis as we speak. As we speak, there are, when Trudeau said, I mean, I know the Prime Minister waited for the public. I guess another point I want to make is that the public makes these things happen. All drug policy reform comes from the ground up. You didn't see the Minister of Health in British Columbia out in the back alley putting up a tent to start supervising injections. But you did see the Minister of Health in British Columbia coming to visit the tent that was put up in the back alley and say, you know, this is actually not a bad thing. I think we need more of them. Volunteers put it up. Peers put it up. People who use drugs put up those tents all over the country now. The leadership is coming. In the cannabis world, leadership came from individuals taking the country to court, the federal government to court, building a medical marijuana program in spite of the fact that the federal government didn't want to do it. Court case after court case after court case. And then Trudeau comes along when public opinion is like at 65% in favor of legalizing cannabis, and he says, I'm going to do it. Shrewd political decision, right? And it's happened. So you got to give the guy in Uruguay credit, because he said the same thing. Only 30% of Uruguayans thought it was a good idea, but he said, we're going to legalize it anyways. Why did you do that, President Mujica? Because it's the right thing to do. And they did it. They did it over a period of years, and they actually achieved it against the will of the public opinion. But the stubborn farmer president that they had said, this is the right thing to do, we're going to do it. And that's what we need. This is a time when politicians really have to stand up and be counted, because the numbers are not going to be much better next year unless some drastic action happens. And the way things are going to change is through drug user organizations, moms groups, civil society organizations, meetings like this that academic institutions have. I think UBC, the president of UBC just brought together a group of people, said UBC wants to do a role. They brought together their faculty and the deans of all their faculties. We need to participate in addressing the overdose crisis in this country, and how are we going to do that? So I hate to say it, and this is the discouraging part. So X number of people are going to die tonight because they're not having access to a substance that they know the composition of. We have those substances in our medicine cabinets, and we're not choosing to give it to them. We're sending them to the street, one way or the other. And it seems like an absurd sort of situation. Why would we be doing that? Why are we so afraid of opening the medicine cabinet and saying, you know, chances of you dying tonight are really, really high. Why don't you come in and have an Oxy 80 or some heroin that won't kill you? Why are we not doing that? And that's to me the disconnect in this discussion. And that's, to put it bluntly, that's what needs to happen, because people in Canada are going to go out tonight, use a substance that they think they bought something that's an opioid, and they're going to die. And these are substances we have. So don't get involved in drug policy is my advice. If you want to have a career, or you have to embrace the absurdity of the situation, and that is the challenge before us to get to a viable solution. I think we have to think really radically. One of the talks I did recently was called Heroin at the Corner Store. And that was because a friend of mine, Bud Osborne, who was my sort of poet, spiritual leader in the 90s as we fought for dinky little injection rooms that we thought would save the world, which are wonderful, wonderful things to have in your community. We used to be accused when we'd say we were for legalizing drugs. People would say, wow, what do you want? You want heroin in 7-Elevens? We say, no, not 7-Elevens, not 7-Elevens. We want it in a clinic, or we want it, in a very nice, controlled environment. There'd be a process, you'd have to get it, and you can't just walk in this. Anyways, he phoned me up about 2 or 3 years into the overdose disaster, and he said, Donald, I think the 7-Eleven model would be better than what we got. Because you'd have to go in and talk to someone, like a real person who wasn't a drug dealer, and you'd be buying heroin. And really, the least worst is what we're looking for, and right now we have the worst. So what are we going to come up with? Right now we have a highly restricted program in Vancouver. And we need to open the doors to safe places and safe supply of opioids in the context of a public health emergency, which should be called by the federal government, should be called nationally, and then try and figure out how to maintain some sort of regulatory system on these other drugs. I'm going to stop there. Oh yeah, I have to stay up here in case
Okay.
you throw things at me.
So hi, I'm Carol Strike. I'm a professor at the Bell School of Public Health, and I'm pleased to see so many people today. Thank you very much for your very insightful talk. And now we have 4 more people who are going to provide some more richness to the discussion tonight. So do you all want to come up, and then I'll introduce you one at a time. So the first speaker, as he makes his way up, is Matt Johnson. He's a harm reduction outreach program coordinator at Queen West Community Health Center. He's a long-time harm reduction worker, advocate, and one of the original organizers of the overdose prevention site in Moss Park. I've heard Matt speak on many occasions, and he will speak every time. So I will, Matt, do you want to come here? Great.
Good at this image. No.
I'm here for the kind of line. And so some other speakers, I think, have a little bit more about sort of what we can do, some sort of looking at the future stuff, but I'm going to be focused on what's going on right now, so it's not going to be as fun. So my name is Matt. I'm a long-time injection heroin user. I'm 35 now, so it's been just over half my life. But I was really fortunate that in my sort of early 20s, I got involved in peer work. At the time, it was really clear to me that I would be living on social assistance and homeless off and on for most of my life. And I didn't really have any prospects, because if you're living in that situation, there aren't a lot of sort of job prospects open to you, where you can be using heroin and still keep your job. So getting involved in harm reduction peer work sort of opened some doors and gave me this greater sense of community, a greater sense of purpose. So I ended up continuing back going to school and then continuing in that. So that's why I'm here. So I run a harm reduction program where I supervise a team of people who are all people with lived experience from the community, who then go out on foot and on bikes and hand out supplies to people who are using and homeless. And so we hand out needles and crack pipes and meth pipes and naloxone, and we do a lot of education and training to try to keep people alive until the next day when we see them again, and try to keep them alive to the next day. Then I get tired sometimes of just trying to keep people alive one night till the next day, and so I come out and do speaking things, hoping that it has some kind of greater purpose. You know, we'll see. I just wanted to acknowledge, as I get up here, that I'm here because of luck and privilege. So I've been luckier than some of my friends because I'm alive, and that's not because I've done anything differently than them, or I figured something out that they didn't figure out. It is really just dumb luck. But then there's also the part of privilege. So I'm a white male, so part of the reason that I'm here speaking to you is that I'm a white male. Part of the reason that I'm standing here today is that I'm a white male, and so I didn't face incarceration or colonization like many of my brothers and sisters have, who have faced many more barriers than I have. And that all of those sort of intersecting oppressions that people face really are just making a horrible situation worse. There's two sort of things that we're chanting when we go out at marches and stuff like that. One is "They talk, we die," and then the other one is "We grieve thousands." And so I'm going to come back to those in my speech, but the "we talk, we die," "they talk, we die," is that politicians, it's not that they don't know this stuff. They've known about this stuff for a long time. The overdose rates in Ontario have been going up for 25 years. So they've known that this has been an issue for a long time. They know all about decriminalization. Donald has spoken to politicians all across Canada. They know this stuff. They're just not doing it because it's not popular enough or whatever. So they'll sit and endlessly debate this stuff while we die. So what I'm hoping is that as you leave here today, what we need is the majority of Canadians to stand up and say, this needs to change, this needs to be different, and that's something that you can really affect it right away. I also just want to say that there's this idea that some of these problems we're having are the unfortunate outcome of criminalization. That criminalization was put in place with the best of intentions, but then we ended up here. And that is actually not true at all. Criminalization was put in place as a way to target, stigmatize, and discriminate against people who are considered undesirables. So the first drug law in Canada was the Opium Act of 1908, which was put in place to discriminate against Chinese immigrants to Canada. Every drug law since then has been a way to target and harass people that were seen as undesirables by the status quo. And there was an aide of Richard Nixon who came out a while ago now saying that when they were doing their big war, the kind of real beginning of the war on drugs in the late 60s, they didn't believe anything that they were saying about cannabis or heroin. They were focusing on cannabis to try to criminalize people who were against the war in Vietnam, and they were focusing on heroin as a way to focus on civil rights activists, particularly young black men involved with the Black Panther movement and other movements like that. And it's no different than today. So what's going on? Donald talked about this, that we are in an overdose crisis. We're not in an opiate crisis. This really has nothing to do with opioids. It just happens to be fentanyl. But a few years ago, we were in a levamisole crisis, which was in cocaine. The only difference was that fentanyl tends to kill people right away. Levamisole was poisoning people over a long period of time, and the death rate was lower, but it's the same issue. And so we had levamisole, that's brought us to fentanyl, which actually is not where we're at. We've studied, for those of us that started the OPS in Moss Park, we've studied the drugs that have been coming in there, and for most people it's not fentanyl anymore, it's fentanyl analogs. So we moved past fentanyl, so some people are having 5 different fentanyl analogs in their drugs, and fentanyl is just a pretty remarkable chemical in that you can make these subtle changes to it and make things like carfentanil or fluorofentanyl, and there are a lot of them that can be made, and some of them are much stronger than fentanyl itself. So we had levamisole, fentanyl analogs, and we don't know where it's going to be tomorrow, but it could have nothing to do with opiates. This is a drug poisoning, and it's about the criminalization of people who use drugs, not really about opiates. So the main thing I was asked to speak about is how does it feel, how does it impact people to be using from a poisoned supply. And I'd say that the biggest thing is that we know pretty deep down that we are not cared about by lots and lots of people. We as a society at this point have done very little to address the incredible number of overdose deaths. And if Doug Ford gets in, then what we have put in place may all be taken away in this province. We're currently facing more deaths than at the height of the AIDS epidemic, but I've yet to see any large multi-million dollar organizations stepping in to sort of tackle this or really pressure governments. The other thing is that decriminalization isn't this fringe idea anymore. I mean, the UN has called out for it. The Canadian Mental Health Association has called out for it. So it's not this odd fringe idea anymore. It's gained a lot of support. You can't refute the evidence that it just works better. But we still are fighting over whether we have a methadone clinic in a small town, or whether we're going to have a safe injection site at this location. We're getting bogged down in these little tiny wars and not actually looking at a bigger picture really at all. It's difficult to talk about the idea that we have deaths higher than the AIDS epidemic because harm reduction and modern harm reduction came out of the AIDS epidemic of the 80s, which made people say this idea of just don't do it just doesn't work. It just doesn't work. So people had to think of something new. So we're going to give out condoms, we're going to give out syringes, we're going to do that. So we're at this new stage with an even greater death toll, but we haven't had that aha moment to say, clearly what we've been doing hasn't working and we need to rethink this and do something drastically different. Not let's have a kinder, gentler drug war. Drastically different. So what's odd to me is that we can do things like I can hand out syringes, and some people are against it, but most people kind of get the purpose of it, right? If we're here to reduce HIV, if we're here to reduce Hep C, people can get that, they can get behind it. But when it comes to transformational change, then we're hitting this wall. And we don't seem to really even be able to have that conversation about transformational change. And again, this isn't new. So I think Donald talked about prohibition of alcohol. We're in the exact same position as we were back then. But instead of Al Capone, we have El Chapo. And so we had the same issue then, where there were an increasing number of people using alcohol after prohibition. There were increased risks as people were drinking bathtub gin, although they did manufacture some really tasty cocktails to make up for the fact that it tasted like crap. But we clearly just don't learn our lessons, right? So how many times do we have to go through this whole rigmarole before we figure out? And my worry is that if we talk about an opiate crisis, we're going to have an opiate solution. And this isn't an opiate crisis, it's an overdose crisis. It's about the drug war, it's about all drugs, not a particular drug. At the same time, as we had an increasing acceptance of decriminalization from academics, we've had a pushback from the other side. And so we have people like Duterte, who is executing not just drug dealers, but also drug users, and then people like Donald Trump, who is praising him for his drug policies. And I have heard a lot of people in Canada call out not killing drug users, but that any of the drug dealers caught giving out fentanyl, they should go to jail for life. They should be executed. As if the drug users are not victims of the drug war as well. As if somebody who's standing on the street corner handing out dime bags, is Mr. Big that should be facing that kind of thing. Sorry, can I have 2 more minutes? Okay. So a lot of people ask sort of why don't we stop facing this sort of large death toll? People use drugs for lots of reasons. People are dependent for lots of reasons, but regardless of whether you believe in a disease model, learning model, or trauma model of why people use, there's going to be a hurt or an isolation that's at the base of that, something that people are struggling with. And when you use, you face surveillance, incarceration, and harassment at a level that most people just would never experience. And so we don't sort of focus on what do we do about that. We focus on the symptom of the problem. I also don't hear people telling people with diabetes that they should kick their insulin habit. But if I use opioids to regulate other body chemicals that exist in my brain or to modulate them or whatever, then that's somehow a very different conversation that we're having. And the people that I work with have lived through the very worst abuse, neglect, and isolation that people face in Canada. And for some of us, the idea of facing that unmedicated is just not realistic. And ratcheting up the fear is not going to help that. I also want to say that decriminalization by itself will not fix this. We need decriminalization and a regulated supply, along with some of the other social supports that can be put into place when you take money away from arresting people and free it up for other types of things. So I said before that it feels like we're not cared about. When SARS hit the city was shut down. 40 people died during SARS. It was a horrible thing, but the city shut down. Right now, Kathleen Wynne won't say that we're in a crisis. Doug Ford wants to shut down safe injection sites. Thousands of my brothers and sisters have died, and we've seen little to no movement. And so a common question I'm asked by people that I work with is, how many more thousands of us have to die before people are going to care? That's all I have. Thank you.
Thank you, Matt, for that impassioned speech. It's now my pleasure to introduce my friend and colleague, Ahmed Bayoumi. He's a professor in the Department of Medicine and in the Institute of Health Policy Management and Evaluation at U of T. He's also a scientist at the Center for Urban Health Solutions at the Leigh Knowledge Institute and a general internist and HIV physician. That's a lot. You're a busy guy.
Thank you, Carol. So I was asked to speak actually about 2 things, 2 quite different things. One was about clinical aspects of decriminalization, and the second is about economic aspects of decriminalization. So I'm going to try and do all of that in 10 minutes, which is a lot. But I want to start actually to ask you to envision a real clinical encounter that happened. So one of my patients was in jail. He was brought to the clinic by the guards, 2 guards, even though he was in shackles, shackled in his hands, shackled on his feet. I went into the examination room, and the guards were there. So I said to them, "Can you please take the shackles off?" And they looked at me, shrugged their shoulders, "Okay." And took the shackles off, and said, and they just stood there. And I said, "Can you please leave the room while I talk to my patient and examine my patient?" And looked at me and they said, "Doc, you know your patient is in jail." And I said, "Yeah, I know my patient is in jail. Can you please leave the room while I have this encounter with my patient?" And they sort of shrugged their shoulders again, rolled their eyes and said, "Well, you've been warned." Right? And they did leave the room. But I want to use, of course, most people who use drugs aren't in jail, but I want to use that encounter as a metaphor. In some cases, as a metaphor, because I think there's always that metaphorical guard at the door, even if there isn't a real guard. But I also wanted to talk about some aspects of that clinical encounter. And the first thing I want to think about is the effect of criminalization on the health of people who use drugs themselves. And I do want to start by saying for some people, the opportunity, the experience of being in jail represents an opportunity to get health care that they might not otherwise get. But that's, I don't think, the most common experience. We know that mortality increases for people who use drugs, particularly for people who use opioids after jail. We know that forced abstinence is one of the most harmful things that can happen to somebody. And we know that particularly in the first few weeks after release from incarceration, that is a particularly dangerous time in terms of death. We know that drug use continues to occur while in jail, and at the same time, harm reduction supplies, sterile needles and syringes are not available in prison. There's been really important work done by Sandra Chu and the HIV/AIDS Legal Network on this. So incarceration itself, we need to really think about whether that's something that we want to do to people who have really, who are in jail. And there are US statistics for this, European statistics for this. I don't know if they're Canadian statistics, but the large majority of people who use drugs are in jail, not for any harm that they've done to anybody else, but for harms that are perceived to have been done to themselves. And for us to put those people in jail and expect that those harms will somehow decrease, I think is naive, and it's certainly not evidence-based. Second point about the clinical aspects, I want you to think again about that encounter with that patient. And I want you to, I want to be somewhat critical of healthcare providers, of which I am one. And to say that healthcare is hierarchical in its nature, and that many providers, when in a situation like that, I think are not sufficiently reflective of the power that they yield. And in ways that are sometimes explicit but often implicit, are a healthcare provider in that situation needs to choose between being part of the system that continues to dominate over somebody who uses drugs, or to be an advocate for that person who is using drugs. And I don't think we do that sufficiently enough, and the criminalization of drugs, I think, helps to feed into that mindset. I would urge anybody who's a healthcare provider here to think carefully, not just about that situation, but even things like asking people to sign contracts, asking everybody who's prescribed an opioid to sign a contract, no matter if there's any concern about that opioid use or not. I think that same legalistic thinking carries over into many other interactions that healthcare providers have with people who use drugs. I also want to talk about discrimination. You'll hear a lot about stigma, but discrimination is actually the active action that people take against people who use drugs that's driven by the stigma. And that discrimination prevents an honest conversation between the provider and the patient around things like what drugs people are using, the consequences of that drug use, and more importantly, perhaps about why people are using drugs, some of the trauma that people have had in their lives. I work in a hospital. I'm a hospital-based physician. It is, perhaps shouldn't be, but it continues to surprise me how frequently people want to deny the idea that people who use drugs will continue to use drugs while they're hospitalized. So, but rather than having that honest conversation and about making that drug use safer, we want to somehow pretend that it doesn't exist, or we want to enforce some rule without thinking through about the consequences of that rule. But really, you know, if we think about our role as healthcare providers as being not just to improve health, but also to maximize the dignity of the individual patient, then we need to think about concepts like autonomy and concepts like privacy, and to think about what that means in terms of the clinical encounter. And I think decriminalizing drugs will help us to address some of those aspects of care that I think many healthcare providers have internalized. And then my last point about healthcare is if we talk about decriminalization, one of the things we very rarely talk about is what comes afterwards to replace it. and I think Donald mentioned this a little bit, but if we move from decriminalization to some sort of forced abstinence programs, we could end up doing harm with the replacement for decriminalization. And so as healthcare providers, we have an obligation, I think, to think critically about what comes next and what our role is in what comes next. Okay, I'm going to switch. How long do I have? 3 or 4 minutes? So I'm going to talk about costs now. I'm going to not be a doctor for a second. So the drug market is estimated to be worth about $320 billion globally, much of that controlled by criminal groups. There are considerable opportunity costs. That's an economic term. It means the cost for not doing something. So if we have police and the justice system, if we spend a whole lot of money on the judicial and the police systems, putting people in jail for something for which jail doesn't actually have positive outcomes, there is a lost cost. We could be spending that money in much better ways. So there's not only the direct costs, there is, I think, a considerable opportunity cost from the way that we think about drugs right now. There are, of course, economic implications at the individual level. People who come out of jail have a loss of earnings while they're in jail, but more importantly, they have a loss of future earnings. So there's evidence, again, from United States studies that people earn considerably less after jail. They have a harder time getting housing. They have a harder time getting jobs. And again, we need to think about, is this something that we actually want to do to people? Donald mentioned some of the evidence from Portugal. There are also some, there have been a couple of costing studies done in Portugal. One estimated that overall societal costs decreased about 18% over the first 10 years of decriminalization. That's a great number. It's a challenging number to interpret because, as Donald said, it wasn't just decriminalization. Portugal did a whole lot of things at the same time, and trying to figure out what proportion of that was decriminalization versus how much of that was some of the other investments, very important investments in improving the health of people who use drugs, is very challenging to tease out. It's also very challenging to try and necessarily apply those cost savings from Portugal to a Canadian context. There are differences in HIV and hepatitis C rates. We have treatment for hepatitis C now, which is extremely expensive, which wasn't available when Portugal first introduced their reforms. So preventing hepatitis C now is actually even more important from an economic perspective than before, because it represents a potentially huge cost savings. And again, as before, the cost effectiveness will depend on the cost, it'll depend on the health outcomes, but also very much will depend on what replaces decriminalization. And I'm going to stop there by just repeating what I said before in the clinical context. We need to think carefully about what comes next, right? So it's good to be in favor of decriminalization, but I'll stop by just asking you to think, and all of us to think about what sort of system we want there that will both maximize the health of people who use drugs and potentially save money. But it's difficult right now to say, for me to stand here and tell you that there's an evidence-based definitive conclusion that decriminalization will save money. I think it might, but it really requires us to be imaginative about what comes next. Thank you.
Thank you, Ahmed. The Dalalana attracts many excellent students, and Nazlee is the most recent shining example of an enthusiastic student. She's a PhD candidate in health services research at the Institute for Health Policy Management and Evaluation at U of T. She has specializations in health policy, knowledge translation, and addiction studies. She's also the knowledge translation manager at the Center on Drug Policy Evaluation, where she plays a lead role in the production and dissemination of drug policy research. And I turn you over to Nazlee. She's an excellent speaker, too.
Thank you so much, Carol. Thanks so much to everyone for being here. It's such a packed room. It's so great to see. And thanks as well to the organizers for inviting me to speak on this panel. So I'd like to start off my remarks by speaking about what is actually the focus of my doctoral research, as well as my role at the Center on Drug Policy Evaluation, formerly known as the International Center for Science and Drug Policy. And that's actually the implementation of drug checking services in Toronto, which Donald alluded to in his talk. So in December, we heard from Health Canada that they would be funding and authorizing drug checking services throughout the country as an opioid overdose crisis response, in recognition that a major driver of the rising incidence of overdose fatalities has been, of course, the contaminated street drug supply, primarily with fentanyl and fentanyl analogs. In Toronto, we were funded for a multi-site drug checking project, 5 years worth of funding for a minimum of 3 sites. And for those that are not familiar with drug checking services, this is a harm reduction intervention that has been available throughout Europe since the 1990s. And what it does is provide people who use drugs with information on the composition and the potency of their street drugs. So what's in it and how strong is it, in order to enable more informed choices about their drug use, as well as increase their capacity to avoid consuming lethal amounts of potentially toxic substances. So in Toronto, we'll be implementing this through a networked model, which will consist of 3 frontline harm reduction agencies, all of which have recently implemented supervised injection sites, and a partnership with hospital laboratories that have what's called gas chromatography mass spectrometry, as well as liquid chromatography mass spectrometry equipment, which are really the gold standard when it comes to forensic drug analysis. So the way this will work is that folks will be able to come to frontline harm reduction agencies, provide a small scratch of their street drugs that'll be transported to the hospital laboratories, which will test that for composition and potency, and then the results will be sent back to the frontline harm reduction agency to deliver to the client along with harm reduction information specific to their analysis results. So this project is set to be implemented in March 2019. Right now we're going through the process of receiving the many different approvals and things that we need to set this up, one of which is Section 56 exemptions. So this is an exemption from the Controlled Drugs and Substances Act that allows services to operate without risk of criminal charges for possessing or trafficking illegal drugs. So supervised injection sites in Toronto and across the country will have these Section 56 exemptions. And the way that it'll work for drug checking services is because we're co-located within a CIS, it'll be an addendum to that Section 56 exemption. Now, the reason that I mention this is because I think that we need to have a recognition that decriminalized spaces actually already exist throughout Canada. Right? Safer use spaces, supervised injection sites, OPS, these are all spaces that are kind of decriminalized, safe spaces where folks can come and exist, use drugs without fear of arrest or prosecution. So that means that we have a recognition from our policymakers that health services targeting people who use drugs can't effectively reach their population and be effective in doing all the things they do in terms of health and social benefits without that removal of that fear of arrest and prosecution. So I think it's also worth noting that not only are there these kind of small decriminalization pockets throughout our country, there's also an example of a micro-regulation, which Donald also alluded to, in terms of the availability of heroin-assisted treatment, which although our federal government has made some recent policy changes to allow greater adoption of this harm reduction service, it is still only available at Vancouver's Crosstown Clinic, serving about 100 people who use drugs. So we have micro-decriminalization examples, we have micro-regulation examples, and I think this really gives us something to build upon, to say, for the very same reasons that you recognize that this needs to happen within these walls, when folks walk out the door, all those reasons still apply. So I think that it gives us something to build upon. The second topic that I wanted to talk about is around stigma, and there's been some great remarks already from some of my fellow panelists. Now, stigma has been a main focus of this federal government's approach, including to the overdose crisis, as well as internationally. So this past March, the annual Commission of Narcotic Drugs meeting was held, which is a meeting held in Vienna every year where all countries around the world gather to talk about global drug control efforts. And this year, for the first time, there was a resolution on stigma, which was led by Canada and was adopted by the Commission of Narcotic Drugs. And by UN standards, it was really quite a bold resolution. Now, negotiations were really quite difficult, and that's because at the international stage, for drug control issues, all matters are negotiated by consensus. So that means what you end up with is the lowest common denominator, right? The same sentence can mean one thing to the most progressive country in the room and mean something totally different to the most punitive or repressive country in the room. That's what agreed language means. So the negotiations were quite difficult, but they were able to have this resolution adopted by the CND, and it included a few key wins, which I'll note. One was the inclusion of people who use drugs in the development of drug-related policies, programs, and strategies as being absolutely critical. Another was about incorporating awareness of stigma training into training for all stakeholders that work with people who use drugs. And another was a mechanism by which we can continue to build on this stigma work at the international level, which was asking the UN Office of Drugs and Crime to report back to the Commission of Narcotic Drugs in 2020 on the implementation of this resolution. So I mention all of this because I think the leadership role that's been taken by Canada, both domestically and internationally, on stigma is absolutely fantastic. We've heard about the barrier stigma poses for folks to be accessing health and social services. But a major gap, of course, remains that the Canadian government has not made this connection between destigmatization and decriminalization. So criminalization is institutionalized, it's systemic stigmatization. I don't see a situation whereby you can destigmatize a behavior that by its very nature continues to be criminalized, right? So for me, that is a really challenging piece of this federal government's position. And I think we've heard about the public health approach and the public health discourse that really does open up the door to destigmatization and moving towards leaning away from criminalization as the approach to dealing with drug-related issues. But I think we also need to be careful with the public health approach, because I don't think it would be a better situation if we were necessarily to replace every single law enforcement official with a medical official or a doctor, when we know that actually 80 to 90% of drug use is not problematic. It would not be a good use of resources to be triaging all these folks into treatment who don't actually need it and diverting those resources from folks that could benefit from it. So I think we need to be careful with just replacing that and be more nuanced in our discussion of a public health approach in a recognition of this spectrum of drug use. So I think, therefore, a cultural shift is really needed. We're not only destigmatizing the fact that people use drugs and sometimes have a problematic relationship with them, and when they do have issues of dependence, we should be giving them support rather than punishment. But also, we need to destigmatize that actually, for the majority of people who use drugs, it is a normal and healthy part of their life. It's something that's existed since the beginning of human history. And if we want to destigmatize, we need to be looking at those individuals on that spectrum of drug use as well, and making sure that our decriminalization policies are really making us better off than under prohibition, which I'm sure they will, but we need to be more nuanced in discussion, and I think some of the points that I've articulated today can help us get there. Thank you very much.
Thank you, Nazlee. Last but not least, I'm going to invite Leigh to the podium. Leigh always speaks with compassion and thoughtfulness, and I'm sure she will do so this evening. She's a registered nurse and a PhD candidate at the University of Toronto Faculty of Nursing, and also a doctoral research fellow at the Wilson Centre. She's the founder of the Toronto Overdose Prevention Society and is the co-founder of the Moss Park Overdose Prevention Site. I turn the mic over to you.
So I'm going to talk a little bit about activism and sort of how I became involved in this. As a mom and busy PhD student, I certainly wasn't looking for a side project in harm reduction that would slowly sort of take over my life. But I started to become involved in harm reduction initially as an advocate about 2 years ago now, following the overdose death of my older brother, Brad. And I started to meet people, some of whom are in this room, who looked after Brad, who knew him, who he was, very involved in harm reduction. He was a client at Toronto Public Health Works, and he was very well known there. And so, I started to meet people who are professionals, who are friends, who are harm reduction workers, people with lived experience, people with busy, very complex lives like mine, who also understood the grief and illogical nature of a preventable overdose death. And so I started to partner with them Initially, in 2016, it was around opening the supervised injection services in Toronto, and really championing the evidence and the science as a nurse. The evidence-based nature of these policies sort of appeals to me, but they're also really it's really about humane care and compassionate care, and following a visit to Vancouver last February, we all sort of took up this call to action to open overdose prevention sites in Toronto, knowing that there were 3 supervised injection services that would be opening last fall, but that they were inadequate, that we were in the midst of an overdose crisis, we are in the midst of an overdose crisis, and we needed to do more. So we did. We opened an overdose prevention site in Moss Park on August 12th, 2017. And this was, direct action. It was Ontario's first overdose prevention site. It was sort of an occupation of public space where we set up tents in a park and said that we're going to deliver health care right here. It's going to be that decriminalized zone. And so I think, now almost 9 months later, we're still in the park, now in a trailer with hydro, and, soon, we will have reached 7,000 injection visits and, have reversed well over 200 overdoses. So I think the voices of activists in this, I sort of describe this as a shift from becoming an advocate to now an activist. But I think, we're perhaps seen as more moderate in this unjust world where the policies criminalize drugs and people who use them and create these barriers to care. In setting up the tents and now the trailer in the park, we've provided a space for people to come in to care. And we know people by name, we have relationships with them, and we're able to build trust, and it goes so far beyond just keeping them alive. But it is also inadequate. So I'm going to talk as well about stigma and decriminalization. I was complicit in stigma. I wanted my brother Brad to stop using drugs and to be there for his 3 children. And sort of because I was complicit, I sort of cast this moral judgment on him that he should just stop using. Now that I know what I know about harm reduction, I know how impossible that would have been for him. He was homeless, he was an IV drug user, he was in this sort of cycle of incarceration, getting out of jail with no belongings, with a criminal record, living in poverty, using drugs, being estranged from his children, and the cycle just would sort of continue. And it continued for him for almost 20 years. So I think, with criminalization, we deny people the same care and privileges that we afford other people because of the illegality of the drugs. And if we were to reframe that and perhaps just view the drug policies as unjust, and recognize that stigma is actually what's killing people, and discrimination underlying that stigma. Criminalization means that people use in alleys like my brother Brad did. They use in bathrooms and stairways, and they die before they can even access care and build those connections and relationships with people who love them. So I think we need to really consider, an ideological shift about the world we want to live in and how we want to treat people who are vulnerable because of these unjust laws. I'm going to talk just briefly about Toronto Police as well. I was asked to speak about Toronto Police partnership with harm reduction workers and perhaps allyship. And I think collaboration with police is something that is really tricky to wrap my head around it because of criminalization. But I think the partnership means involves meaningful understanding. I had an opportunity last weekend to take 2 uniformed officers into our trailer when we were not open and sort of give them an orientation to the site and a simulation of what it's like to have somebody come into the space. And they had no idea and sort of said, I don't really understand addiction. And I don't know how, it's a really dismissive statement. I think we don't generally say, I don't understand diabetes. I don't understand obesity. I think it's incumbent upon all of us to figure these things out. And so I think, when we think about the Toronto Police, this was a great teachable moment and learning opportunity, and I think we need to demand more than just naloxone, police carrying naloxone. It's about a humane and just response to people who use drugs, a compassionate understanding about the people who use drugs. They're so much more than their drug use, and realize that the surveillance and the criminalization is actually denying them people care. So it's actually causing death. And I think that would come a long way if police were to acknowledge, their complicity, their role in criminalization and its impact on people's lives. I think that would go a long way. I think we have a long way to go. Ontario and Toronto specifically has scaled up very quickly. Initially from our overdose prevention site in Moss Park to having 4 Health Canada sanctioned supervised injection sites and other overdose prevention sites that have been opened and others that are soon to open in the city. So I think it's up to the police to sort of get on board with this in terms of understanding and understanding what the implications of criminalization are. I just want to close and acknowledge people in the room and perhaps those watching online who have lost a loved one to overdose. And I know there's many who have sort of reached out to me, parents who are struggling with children with overdose, who have lost loved ones to overdose. And I know how hard it is to hear the science and the logic around decriminalization, because I think it accentuates the preventable nature of the deaths and these losses. And I think, we need to keep talking about this, and we have to live with the hope that in our lifetime that these laws will be abolished and they will change. We need to keep talking about this with people who disagree with us, tell the stories, humanize people's lives and deaths, and prevent the deaths, of course, but certainly we need to share these stories and really the logic around evidence-based drug policy. And I'll close there.
So I'd like to thank all our speakers for their very thoughtful and very personal remarks this evening. So what's going to happen now is I'm going to ask the panel a few questions, and then I'm going to turn the mic over to the audience, and I'm sure there are many of you that have questions. And so do we have a roving mic when that happens? How is that going to happen? Or people can just stand up? Okay, so we'll ask you to shout it out when we get to that. So the first question I wanted to ask is, so Ahmed suggested it, but what comes next, right? So we're here tonight, we've made some suggestions, so what does come next? And any one of you take that question, maybe Matt?
Sure.
Yeah, please.
How about if I say what I hope happens next, not what's going to happen next? What I would like to see happen next is that we all leave here, take it upon ourselves to pressure our politicians to enact some change and movement on this. That we look to places like Portugal and other places to see what they've done, but also, this is something that's been looked at in Canada as well, so that we move to decriminalize, regulate, but also to create a regulated system that's based in an understanding of the dignity of drug users and also the need for pleasure, that if you try to remove the pleasure aspect from use, like we already have a methadone system where it's very tightly regulated and it's about abstaining from other drugs, that like we're still in this system, so we need something new that's understanding of those types of issues, or that stuff as well. And then we could put a lot more money into doing more than just trying to keep people alive, because it gets frustrating over time. Like Leigh mentioned her brother Brad getting incarcerated over and over again. So one of the reasons why it's difficult one of our jobs is to try to connect people to greater care, but it gets very difficult when we build a relationship with somebody and then suddenly they're incarcerated and they're gone for 6 months. So then when they get out, we have to start all over again. So regularly, any progress that's built up gets destroyed by being incarcerated. or we connect somebody for a while and then their doctor finds out that they're a drug user, and then they get a whole bunch of their services restricted or taken away from them. So it's often this kind of building stuff up, only to see it kind of knocked over. And I think that that although decriminalization doesn't fix everything, it does create a greater likelihood of being able to do some of those things on a more sustainable, in a more sustainable way.
Donald?
Were you going to go, Ahmed?
Yeah, I'll say quickly, I think I would hope that we do three things. One is that we don't do things that are harmful, and we know that there are things that are harmful beyond just criminalization. I mentioned forced abstinence, right? So there is a danger, I think, when we talk about decriminalization, that people will default to doing things that are still bad. The second thing is, you know, we know from over and over that there needs to be a comprehensive set of responses, right? We need to address housing, we need to address employment, we need to address people's trauma, we need to address a whole bunch of different things. So, you know, one of the things I think Portugal did right was that it wasn't just about decriminalization. As Donald said, you know, and one of the things that frustrates me when people talk about Portugal is that they focus only on that, as Donald said. Right? We need that comprehensive set of responses. And then the third thing really is we need to recognize that we need to meet people where they're at, right? So opioid substitution therapy is a good option for some people. For some people, it's not a good option. And so prescription heroin or prescription hydromorphone is a good option for some other people. And we need to think about a variety of public health and healthcare responses that can address the different needs of people and the changing needs over time of people.
Yeah, I thought about this question, and I think that there's two things that need to happen, and one is like, and I don't want, the federal government has, British Columbia and Ontario have declared a public health emergencies. Is that right? Ontario declared one last year? No? Oh, I'm making that up. That's a what do you call it? A fake fact or fake news or something? Okay, BC is the only jurisdiction that's declared a public health emergency, and there's been a lot of pressure on the federal government to do that. They say there's nothing that would give us that we can't already do. So I don't really want to get into semantics with the federal government, but they should declare a public health emergency. It would be very meaningful to a lot of people at the very least. But immediately strike a task force on a very tight timeline to determine the most efficient, fastest way of disentangling what is the real demand. As we know tonight, there is a real demand. People will be buying drugs on the street corner tonight in cities across Canada. What is real demand for psychoactive substances, to disentangle that from the criminal marketplace. I don't know how else to say it. And a transition to a regulated, controlled marketplace with strict enforcement on criminal organizations who do not comply. So basically take the market away from organized crime and unregulated dealers. And that sounds like a big job, and it's going to take us forever, maybe never, but that's why I tried to word it differently. We have an emergency. Get your best epidemiologists, like that guy down there, and your best people who use drugs, like Matt, together in a room for a week and say, come out with an assessment of the demand for opioids in Canada tonight, today, this week. How many hundreds, how many thousands of people are going to go to the street corner and try and figure out a plan to disentangle that from the criminal market? It can't be that difficult. We would do it with so many other public health emergencies. If the water was poisoned or the food was poisoned or SARS, we'd have we'd have a massive workforce trying to do this, and that's what we're not seeing. Instead, we're having a anxiety-ridden group of healthcare people trying to build a system of treatment as fast as they can, and we know that is good, but we know that takes time. So there's some way of just calling the question, look, get our best brains in a room for a week, throw some money at them, tell them to figure this out and come up with a bunch of options for us that could work in the context of an emergency. It'll take years to figure out the best way to regulate all these substances. It'll take more than a year or two, you know? Anyway, that's all I can think of, but, and I don't know why it was not happening. Maybe we're not asking the right person.
Maybe I'll just add, I wanted to let folks in the room know about kind of the current prospects amongst our federal political parties for decriminalization as an election issue in our next federal election. So for those that might not be aware, the Liberal Party had their convention, I think just a couple of weeks ago now, was quite recently. And what came out of that was that a proposal around decriminalization was voted by the membership as not only part of the 5 key proposals that came out of that convention, but also the 3rd most important. Now, the Liberal Party is not in any way required to adopt those proposals or to include them in their election platform, but at least what we're seeing is that there is quite a strong call coming from inside the party where folks are thinking about these things and are aware of this evidence that we've said to them time and time again, and perhaps this could be an election issue in the next federal election. And of course, just to note that the NDP as well did include decriminalization of all drugs as a key element that came out of their convention, although that's been something they have supported for quite some time. So in terms of political prospects, something to keep our eyes open for, although it's much later than we would hope to see action on this issue, of course.
Sorry, another thing is what Ahmed talked about having those systems in place to support people, not just decriminalization, is that also like not waiting for decriminalization to build those things, because there's a lot of stuff that we can do now. Like I know some doctors and nurse practitioners that would like to start prescribing hydromorphone or diacetylmorphine to people as an opiate substitution therapy, but they are worried that it's not clear whether you're really allowed to or what that would mean if you started that process. So that's something that doesn't require decriminalization to begin. We can start setting that stuff up. And the same as for a lot of folks that are homeless and using to get housed, you often are housed in places where you're not allowed to use substances. So people get housed, get caught using, get evicted from their housing, and then end up back on the street. And it's this cycle again and again. So we can set up housing that people can use in. We can set up these things without waiting for the government to argue for 10 years about what decriminalization should look like.
Thanks very much. So I have a slightly different question now. So a lot of the work that Ahmed and I have done, and with other work I've done with other people in the room about needle and syringe programs or supervised consumption services, we get asked the question, well, what about the youth? Like, what message does this send to the youth? What's going to happen to the youth? And so I just wanted, if you could think about, what decriminalization means for young people in Canada.
Okay.
Or
Yeah.
anyone.
No, I'm totally happy to speak to it. One of my former roles was as chair of the board of directors of Canadian Students for Sensible Drug Policy. So we really prioritize youth-related issues within drug policy, and this is, of course, of prime relevance. So I think something that we've seen, particularly with cannabis policy and enforcement, is that youth have really been disproportionately targeted and have bared the brunt of criminalization in terms of arrests when it's come to cannabis. And policies of decriminalization, as well as harm reduction services that are targeted towards youth, I think that the message that they send is, rather than endorsing youth drug use, as some critics may say, it's saying that when we say we need to protect youth, we're talking about all youth, including those youth that do choose to use drugs, because those youth will always exist. Drug use there will always be a subpopulation of young people, whether it's experimentation or dealing with issues in the home or whatever it is, that will be motivated to engage in drug use. And in a lot of ways, it is a normal kind of healthy part of being an explorative young person growing up. So I think that we need to stop thinking that protecting young people means abstinence in all cases for everyone, when that's not actually the reality for a lot of young people, and they are given a disservice when that's the approach we use. So really, we should be thinking about protecting youth in the context of making sure that is inclusive of young people who choose to use drugs, and not pushing them towards the criminal justice system, and making sure that they have the different health and social resources available to them to reduce the harm associated with any drug use that they do choose to engage in, so that they grow up to be healthy, happy humans. So I think that's really, really critical.
I think it's a little naive, too, to think that telling youth to do anything is going to work. So I'll just speak about myself. This is going to get a little dark, sorry. So I'm a kid of the 80s, and so I grew up on that egg, this is your brain, the crack the egg, this is your brain on drugs. So when I started using, which was quite young, I thought there was no safe way to use, I knew cannabis was a bit different, but I thought there was no safe way to use drugs, and that if you started injecting heroin, then that was it, your life was just over and you were going to die this miserable death, because that's what I'd been told growing up. But for me, the alternative was so unappealing that it was worth taking those risks to do the drugs to give me some relief from what was absolutely going to kill me. So doing drugs saved my life and made me get through my teen years to be an adult and make some changes to gain some peace. But I did all that stuff with this absolute assurance that there was no safe way to do it, and this was going to kill me. And I did some dangerous things because I didn't have any other information that I would not have done. I was really fortunate when I was 15, I got hooked up with a harm reduction worker that taught me about safe injection, and suddenly I knew something else. And because of that, I had some different options than some of my friends who ended up having some lifelong implications because of that lack of information. So the idea that the opposite of the harm reduction is going to have an impact or have some kind of positive impact, I think, has not played out. We have decades of the drug war to show that that's not working.
The only thing I was going to add to these very thoughtful comments are, like, there's no age of majority for drug use, and I think it is naive to think that people, that youth won't use drugs. I think when we think of harm reduction, it really is about reducing the harms associated with drug use, and I think typically harm reduction is sort of agnostic about drug use. It's not a pro-drug use. It's not encouraging drug use, as many people think. It really just is about using drugs in a safer way. And of course, why wouldn't that be a goal for everyone, particularly our youth?
Thanks very much.
Okay, start quickly. In some senses, it's an empirical question. Do harm reduction interventions increase drug use? And really, there is no evidence that that is the case, even though you'll hear people say it all the time. There are many reasons why people don't use drugs. And to think that criminalization is the main reason why people don't use drugs, I think is applying a view of the world that one wants to believe rather than a view of the world for which there is evidence. I think cannabis aside, because I think it is different, there really is not strong evidence that one way or the other that decriminalization will or won't increase drug use. And quite frankly, if decriminalization allows a more frank discussion about drug use amongst youth, then that's a really good thing.
Thanks very much. So before I turn you over to the audience, I just have one. I want to start from where Donald finished. You noted, well, you didn't finish there, but you noted that decriminalization won't be perfect. That doesn't seem to be a message that sells in an era of sound bites, tweets, and the like. And although very honest, and anyone in public health or any science-minded person knows that no solution is perfect, right? How can that message be sold or managed?
Well, you heard me. I use the least worst, right? But that's very cumbersome. It's not a very positive message to get out there either. I think you have to take Ahmed's numbers, and you have to basically gather the economic realities, the cost savings. Washington State just released numbers on the cost of the overdose crisis in Washington State, and they calculated it was $9 billion last year, and that including lives lost and loss of productivity and all those sorts of stuff. So, I mean, if people don't begin to understand that, beyond the cost of losing lives, the cost to the community in every which way. And I'm saying this sort of hopefully, but I have used this before, and it hasn't cut it, in the sense that the politicians that I was speaking to were saying, well, we're not going to spend money to save money. Sort of short-sighted.
You have to speak on it?
I mean, Carol and I have some battle scars from supervised injection work that we've done together. People, I think, sometimes forget how controversial that work was a decade ago. Now it seems like everybody's in favor of supervised injection, and it wasn't always the case. Not everybody is, but it's become a much less controversial thing. My mom is in favor of supervised injection. I think there's a lot to be said for all of us advocating in ways that we can, whether it's from an activist perspective or a scholarly perspective, from an evidence-based perspective, from an ethical perspective, and change does happen. It sometimes happens too slowly, but so I actually don't know when change will happen, but I think there is real value to doing the kind of work that we do.
Yeah, maybe I'll just add, I don't have an answer to your question, but just to say that, yeah, you're absolutely right. Like, the drug policy reform narrative is nuanced and it's complicated, and they don't fit into sound bites, and it goes against what people have been taught all their lives about how drug policy should work. So I think that makes it really challenging. There are some wins in terms of things that were described, like the family voice, for example, coming forward, putting a human face on, these are the children that have been lost. They're not just numbers. They're actually folks that have mothers and fathers and brothers and sisters. And I think that that can appeal to some folks. And also there are certain, what's the expression? Unlikely bedfellows, folks that, from law enforcement or different kind of sectors that you wouldn't necessarily normally expect to be an advocate or a strong voice for drug policy reform, but you have somebody in law enforcement who's seen for decades that what they're doing doesn't have a meaningful or tangible impact on the drug markets. Getting someone like that to speak to these types of issues, I think, can sometimes have more of an impact for folks than, not to undermine epidemiologists, but sometimes it's great to get the greater array of voices, given that different ones can appeal to different folks. So in terms of how to make the messaging into a soundbite, I don't know, but the more people saying it, the better for sure.
Okay, thanks very much. So now I'll invite questions from the floor. Does anybody have a burning question they would like to ask? Yes, please.
Thanks so much to everyone tonight. This has been really interesting. But I'm wondering why we're talking about decriminalization and not legalization. Any thoughts?
Well, it's funny. None of us use that word because it's a toxic word. We were talking about regulation to some extent, and it's a process. And I was just thinking in terms of health equity, when in BC, when there was and other places too, when there was an emergency response has been to put sort of fast access to treatment clinics or people or resources into place so that you can get onto Suboxone really quickly and that sort of thing. But that would satisfy so few customers out there. So, and that it was a good thing, but there should have been beside it sort of, if you're not ready for this door, how about some fast access to a safer supply of substances? You know what you like, and and so I think I think regulation, as Nazlee said, is beginning to happen in that micro way. The heroin clinic in Vancouver, which needs to be scaled up across the country. Why it's not? That's one of our problems. We have a living example in Canada of regulated access to hydromorphone and diacetylmorphine heroin in operating already, and why isn't that being scaled up to 5,000-6,000 people across the country? But you're absolutely right. I mean, the other thing I was going to say was what I really want a politician to say, and everyone else in the room, including leaders of healthcare organizations, is that this is a catastrophic failure of our policy framework. It's the catastrophic failure, and it's sort of only when you really acknowledge that you got a problem can you get to that next step. And if people don't see it, it's like this thing, fentanyl is out of our control. It's going on out there. It's like the criminal market is like the sun. It comes up every morning and sets, it comes up every night and sets in the morning. It's like we can't control it. We have nothing to do with it. So we have to acknowledge the catastrophic failure of our drug policy and assign some people to reinvent it.
Something I haven't understood about fentanyl, it seems like a really bad business plan to kill your customers. And is it very cheap? Why is it a good idea to the dealers? I don't understand why it's there suddenly.
So it can be a bad business model for the guy on the street that you're buying it from, but that person is powerless. They probably don't know that it has fentanyl in it. So fentanyl, it started off because you could get it quite easily from pharmaceutical companies in China. Fentanyl is significantly more potent than heroin, so it's moving a smaller package, so it's easier. It also is made entirely in a lab, so you're not having to worry about, to make heroin, you need fields and fields and fields of poppies to make product. So you eliminate all of that. So from a getting it into the country, so sort of smuggling perspective, it's incredibly lucrative. Because it's so potent, you can get a lot more money out of it for a package. I think, too, that I don't think people think this is going to kill people. They think this is going to be really popular because it's going to be so strong. So I don't think it's this idea like, yeah, I'm going to go out and it's going to kill all these people. And the other thing is, like, a lot of the poisonings aren't necessarily people putting fentanyl in things, but sometimes it's like people are using one scale to weigh up stuff, and then so sometimes it's getting it's people who aren't being careful about how they're managing different drugs is how it's getting in.
And it's really cheap.
Yeah.
Profit margins
Really cheap.
are huge, and the risks of getting caught are way less than big kilograms of other substances.
And the Trudeau government decided to do a sort of a crackdown on fentanyl from China, and what they were assuring is that fentanyl analogs were going to be used instead. So if you crack down on fentanyl, people are going to move to carfentanil, which is significantly more potent than fentanyl is. And that idea of going to different analogs is, we don't know how many analogs they can go through before it ends. So there's the other thing is that the thing about police doing crackdowns and it not having an impact on the street. I agree that it does a little bit, but the impact is that the number of overdoses go up. Because when you take that product off the street, they're not going to just say, oh, there's no product on the street today. Somebody's going to come in with product to fill that void. And there are some people who stockpile large quantities of drug waiting for a drought, because then you can sell it for a lot more than you bought it for. But there's also people who put out very weird products because they're filling that void, and people have died from that. So when I see those news things with the police very proud of themselves for all this drug they've taken off the market, I just think, I'm thinking about all the people that are going to die because they've managed to do that. Yep.
What are things that we can keep doing? Because it does seem like we can't necessarily, rely on the government to kind of do these things. What are things we can do right now, like in addition to calling our reps and stuff?
I mean, we've seen a lot of stuff happen in Toronto recently, and I think them having an OPS open in Moss Park had a lot to do with that. And so if people continue to do that, there will continue to be, it does not look good to send the police in jackboots and take down a bunch of people who are just trying to keep people alive. And that's when we opened Moss Park, we invited the media because we were like, this is what's keeping us safe. Because if they go away, then we are going to get dragged out of here. And I've talked with people that if Doug gets in, and the other thing is he may not close the things that exist. It's easier to block new things from opening than it is to close things that currently exist. But he'll certainly block or make it extremely difficult to open new services. And so we've talked about how we just have to go back to opening it in the park instead. And I would invite everybody in this room to come out and help us out.
I think there's also an opportunity at what Matt said, but also an opportunity to counter the narrative that he's sort of spewing around treatment versus supervised injection, and there really isn't a lot of evidence that goes into treatment. A lot of them are abstinence-based, they're not community-based, they're not harm reduction, they're not following a harm reduction model, they're often based on religion and rhetoric, or they're really, really expensive, like his brother's rehab facility. So I think, if we counter that with what the evidence actually is, like there's a lot of evidence around harm reduction, let the science speak, so to say.
There is, but I think it's painfully obvious to everyone in the field that the policy framework itself is standing in the way of a lot of that innovation, and that would be, I think it is just so obvious that it's hard to get beyond that when you see who we have given the drug supply to. It's hard to find, what happens is usually you end up with 101 ways to help someone stop using or get into a treatment program, or you sort of have to work around the elephant in the room, which is the toxic drug supply. So, I mean, I've racked my, as you know, Nancy, that's my sister, she's an evaluator. We have all the evaluators in the room, put your hand up. We need you, we need your minds, because she asks these tough questions. And it's like you're trying to do what you want to do, and I totally agree with you, and yet there's this elephant in the room that says, I'm going to make it hard for you to do anything different, really different, because I'm holding this space that's got so much power. Now, help us. Give her a microphone.
Okay, so no pressure, Tim, but you get the last question.
Okay, so Ahmed said something that has just stuck with me. It was said in a joking way, but your mother supports it. And I actually thought, I had a conversation with my mother, who's 72, who's also supportive of supervised consumption site, and she's the last person in the world I thought of. And as you were talking to me, it was like thinking about strange bedfellows, right? And I remember the law enforcement against prohibition group of police officers in the United States that were at the drug policy conference. So I'm just kind of curious, who's the most surprising person you've met that said they were supportive of the policies that you kind of dropped it? And is there something we could learn from that? Like, is there something that convinced
I think we've tried that. I mean, what I found it surprising when some people on the extreme right started coming out in favor of decriminalization. But they're libertarians, so they're coming at it from a very different view than we are, which is, yeah, I don't care if you go do drugs. I don't want to pay for it, but I think it's horrible, and I don't want you to have any services either if you need help, if you break your leg or your house catches on fire. And we've tried some of those things. So for a long time in harm reduction, we were using the cost thing to try to get conservatives on board to say it's the fiscally conservative thing to do. It's the human rights, just morally right thing to do. But it also, for every dollar you spend on harm reduction, you save $7 in other healthcare costs. And all those people who claim to be incredibly fiscally conservative, I haven't found any of them who've come on side just for the financial argument. So there's this other sort of knee-jerk thing, and I've had conversations with people where you can see they're really struggling with this, and they have no real basis for what they're saying. They're not basing it in facts. They are struggling with some feelings, this knee-jerk gut reaction that they have that they just can't get over. So, sorry, that's not really answering your question, but it's, you know.
I think, for me in Moss Park, we've had, neighbors who have said that we shouldn't be in the park, and, we're prolonging people's trip to heaven, and it's a party in the park every night, and, and which is really hard to hear when we're delivering a vital service. And I think the most surprising, supporter, I guess, or ally has been a residents association in the surrounding area around Moss Park. I mean, there's a concrete platform pad and a sharps container in the middle of the park now, and there, that we collaborated with Toronto Public Health and Parks and Rec to install. We have a trailer, we pick up syringes, but we're also occupying space in a public park. And so that was really surprising for me to have support from a residents association. And yeah, just, there's sometimes the quieter neighbors perhaps, but they're definitely allies there.
Actually, I can't answer your question. I think it was John Tory was the oddest one.
Yeah.
Because he had come out against them before, and his thinking on it evolved over time. And it's not that he's the most, out there supporter of decriminalization, but he has supported the legal safe injection sites, and he certainly didn't do anything to try to have the Moss Park OPS shut down. So he gave me a little bit of hope for some other folks that they could come around on this issue.
If we're talking politicians, I would also say Kathleen Wynne, because she came to the park with Eric Hoskins, who was then Minister of Health, and Kathleen Wynne brought her daughter, who's a nurse. And, that was really important when we were organizing the logistics, that she have her daughter as a support. And, her daughter was totally on board with it. And so I think that was really helpful for her to understand and see what we're doing.
So, it's been said that politicians lead from behind, right? And we had some public opinion data that we analyzed, and it's actually the majority of people in Toronto, the considerable majority of people in Toronto that are support supervised injection. When a report came out 5 or 6 years ago now, my son happened to be home one day. He was in his early teens at the time, and the letter carrier, he was on the porch, the letter carrier came up and sort of handed him the mail, and he said, "Your last name is Bayoumi?" And he said, "Yeah." He said, "Is your dad the guy who did the supervised injection report?" And my son said, "Yeah." He said, "Good for him. I support that." Right? And I think to me that's actually the support from a few crucial people in decision-making powers is important. When the chief of police said that he was not going to oppose supervised injection, that's important. But it really is, I think, the building of large coalitions, and politicians do look at polls, right? So when the polling data is strongly in favor of supervised injection, that matters.
I was still thinking of my sister's question. Where were they? And I was thinking of the Colombian peace treaty, when the Colombian government engaged the FARC. And I know there's been examples in the U.S. cities where police and community leaders have engaged gang leadership. And that's the trouble. You can't get the actual people running the alternative system in the room or have a conversation with them, because, and that happened out west with Eric Costin, the guy in charge of regulation of cannabis for the federal government. He was invited to a meeting of growers, and not all of them were licensed growers. So it's if there were a dialogue possible with people who run this parallel business, that would be really interesting, but you can never really get there. You get an X here and an X there, but if there was some incentivization of that conversation, because a lot of the people in the industry probably would prefer not to have the risk of incarceration, the risk, maybe the high-level guys know, but incentivizing discussions with those people in the context of an emergency, and let's all work together, and why are you killing your clients, and all that sort of stuff. I mean, obviously I'm dreaming, but it's a nut we're not allowed to go there. Just see it perceived as too risky.
I want to thank you all for coming here this evening to remind us to think broadly and deeply, particularly to keep talking about these issues, and what Matt said, to act, to do something. So thank you all for coming, and I hope that tonight's session inspired you to think something differently and to do something. And I invite you to our reception and to interact more with our speakers. So thank you all for coming.